Good evening, everyone. I'm Dr. Aditi Trivedi, consultant obstetrician, gynecologist, and fertility specialist practicing at Surya Hospital, Chembur. Today, I'm going to discuss with you all a very important topic related to pregnancy, that is high risk pregnancy. Now, every pregnancy is precious, but when it is called a high risk pregnancy, we'll be discussing about that today. So, what is basically high risk pregnancy? High risk pregnancy क्या होता है? कौन सी pregnancy को high risk category में हम लोग include करेंगे? So, any woman who is more than 35 years of age and is pregnant, any history of BP, high BP, diabetes, any heart disease, or any chronic disease, be it kidney related disease or liver related disease, which you are aware about prior to conceiving, those females will fall in high risk category. During pregnancy, in certain situations wherein the BP increases, which is called as pregnancy induced hypertension, या sugar increase होता है, which is called as gestational diabetes, or the growth of the baby is restricted, the liquor, that is the water surrounding the baby, decreases, twin or multiple pregnancy, बार बार अबॉर्शन होने की हिस्ट्री रहती है, वो सब pregnancies will fall in high risk pregnancies. So now we'll be discussing each one by one and how to go about it. So before planning pregnancy itself, a woman should undergo preconceptional counseling to get a basic workup done, whether our thyroid levels are under control, sugars are normal. We do a last 3 months blood test for detecting any sugar levels, which is called as an HbA1c. So if HbA1c is high, that means that you are high chances of you are already pre-diabetic, and which may affect your pregnancy. Your BP is being measured, and any other disease which you are having, which you need to discuss with your obstetrician and gynecologist before planning a pregnancy. During pregnancy, we need to monitor these pregnancies very closely. We have to monitor certain blood levels, BP during every visit, sugar at regular intervals, and obviously routine sonographies can also detect whether any comorbid situation is affecting your pregnancy. Now, BP can be chronic hypertension or it can increase during pregnancy. So, what is chronic hypertension? That is, you're already having BP since a long period of time, and now you are pregnant. So now how to go about it? Certain BP medications are not allowed to be taken during pregnancy, so you need to consult with your gynaec and accordingly change the drugs and monitor the BP accordingly. Then there's something called as pregnancy induced hypertension and preeclampsia. So, in these conditions, what happens is that the BP develops while you are pregnant, that is during most probably in the second trimester and third trimester. Now, who all patients fall in category in which there are higher chances of developing BP during pregnancy? One is obesity, when the BMI is high. Second is advanced maternal age. Third is any autoimmune disease like Apla syndrome. So, in such patients, you may be having underlying autoimmune disease, but before you have never conceived, so you may not even be aware about it. In such patients, there are high risk of early trimester, early pregnancy abortions, or the BP may suddenly shoot up during second trimester. There may be episodes of bleeding during pregnancy or spotting during pregnancy, or during second trimester, you may see that there is growth restriction. So, these are the patients who are not high risk when they conceive, but during pregnancy, because of this associated complications, they fall into the high risk category. So they need serial monitoring. They need addition of certain adjuvants like aspirin and enoxaparin injections in therapeutic doses. Serial monitoring on sonography about the to check the growth of the baby, whether it's happening okay, or what is surrounding the baby is being maintained, and accordingly we have to treat them. And the worst complication which can happen related to hypertension is preeclampsia and eclampsia. So, in layman's language, preeclampsia is nothing that BP shoots up a lot. आपके blood parameters derange हो जाएंगे. You have a high chances of convulsion. Convulsion मतलब आकड़ी आना, झटके आना. So To prevent that complication to happen, your BP has to be monitored very, very closely. Your blood parameters have to be monitored extremely well to prevent further complications related to hypertension during pregnancy. So, the common signs and symptoms, these are the warning signs and symptoms of feel extreme severe throbbing headache, especially in the back of the neck, which is called as an hospital headache. Your eyes will feel heavy, you will feel dizziness, you may have episodes of vomiting or epigastric pain, that is acidity जैसा pain होना in the chest. So all these are warning signs and symptoms of raised BP levels, and you should contact your gynec, or you should go to the nearby hospital as soon as possible to get your BP measured, and if it is high you need to get them under control to prevent any further complication. Another complication can happen during pregnancy because of high BP's antepartum hemorrhage, wherein because of such high levels of BP, there will be internal bleeding, which is called as an abruptio placenta, which is an emergency and you may have to be delivered immediately. Now, related to diabetes, again, you may be pre diabetic before planning a pregnancy, or you may develop gestational diabetes during pregnancy. So, all pre diabetic patients, before planning a pregnancy, get your fasting sugar levels, your postprandial sugar levels, your HbA1c measured. If they are on a higher side, please get them under control first before planning a pregnancy, because diabetes is related to a lot of congenital anomalies. आपके बेबीज में abnormalities आ सकती है related to the nervous system. If your sugars are not under control during the first trimester, it may even lead to abortions. Later on during pregnancy, your baby may be maybe large for gestational age, wherein the growth is going much ahead than your weeks of gestation, or it may also lead to fetal growth restriction. So your HbA1c should be within normal limits before planning a pregnancy. Now, gestational diabetes, there are various stages at which during pregnancy we screen for diabetes. Now, that is at around 24 weeks, we do a glucose tolerance test wherein your fasting blood sugar is checked. Then the patient is asked to take 75 grams of glucose orally, and the blood sugar levels are measured 2 hours post giving this sugar to see how well the body is tolerating sugar. So if there is raised levels, that indicates that you are having gestational diabetes, and probably with proper diet, it may come under control. If the sugars are not being maintained, your doctor may advise you oral hypoglycemic agents to control your sugar levels, or may even add insulin. Whenever you are diabetic or having gestational diabetes, it is extremely important to keep a close watch on fetal movements, because you will be the first person to come to know whether there's something abnormal going on with your baby, because this high sugar levels in your blood are passed on to the baby. Now, what does that cause to the baby? Because of the high sugar levels in the baby's blood, it causes increase in the insulin levels. Now, insulin is a growth factor. So it will accelerate the growth, overall growth of the baby. So that's why it results in large for gestational age baby. So probably at 30 weeks, the size of the baby may be 33 weeks. It may lead to polyhydramnios, that is a lot of liquor, increased amount of amniotic fluid, that is the water surrounding the baby increases. Or it may even lead to fetal growth restriction, wherein the growth of the baby doesn't happen properly. Coming to recurrent pregnancy loss. Now, a patient who is having history of multiple abortions in the past. See, even one abortion, obviously, no patient would want an abortion to happen again. So, any abortion, any history of abortion, you need to work up the patient properly. So, your gynec may do certain blood tests to rule out any autoimmune condition which would have resulted in abortion, or any genetic problem which would have resulted in an abortion. So if it's an autoimmune condition like I discussed before, like APLA, or some arthritis related or autoimmune thyroiditis, your gynec will put you on additional medicines and pregnancy support to avoid an abortion. Now, whatever treatment we give, we try our best to prevent an abortion. It may prevent it by 80%, but still there is 10 to 20% high risk of you having some complication during pregnancy. There may be fetal growth restriction, or the LICA level may decrease. You may go in preterm delivery. So all these complications can be prevented as much as by 80%, but it may still happen irrespective of we giving you treatment. So, coming to another form of recurrent abortion is second trimester abortions, wherein suddenly at around say 15 to 16 weeks of pregnancy, you may just go in labors, which is called a silent labor, where you may not even experience any pain, and suddenly on sonography you see that the mouth of the uterus has opened up and you are about to deliver. So this is something called a cervical incompetence. So any patients who is having a history of such abortion, that second trimester abortion, which is called as painless labor, wherein you don't even come to know that the mouth of the cervix has opened up and you deliver. So to prevent that in for future pregnancies, what we do is something called as laparoscopic interval circulage, wherein laparoscopically we put a tape around the cervix to prevent abortion in the future pregnancies. So whenever you undergo any circulage or any such previous history, that pregnancy will definitely become high risk. Your gynec will advise you serial monitoring on sonography to check the cervical length, and you may require additional bed rest throughout the pregnancy to prevent any preterm labor. They may put you on tocolytics, that is to prevent labor pain to happen earlier and to prevent an early delivery. Now let's discuss about IUGR, which is fetal growth restrictions, which can happen in any pregnancy. Obviously, like we discussed previously, any high BP, diabetes, or cardiac disease, or any autoimmune condition can lead to fetal growth restriction. But any normal pregnancy patient who is not having any comorbidities, in those patients as well, fetal growth restriction, sudden decrease in liquor can happen, which may not be predictable. So, in such patients, the cause could be anything. It could be any infection. It has been seen in COVID patients, post COVID, that the liquor has decreased or there is growth restriction happening. Any viral fever, for that matter, can result in this. So, in such patients, what we have to do is that your gynec will ask you to come for frequent visits. They will monitor the baby's growth on sonography. They will do something called as Doppler readings after if the gestational age is more than 30 weeks. And they serially monitor whether the baby is safe inside or whether you may have to deliver earlier. Then comes multiple pregnancy. Now, multiple pregnancy post IUI and IVF are already precious pregnancies because those patients have waited long to achieve a pregnancy. So they anyways become precious. We have to monitor them closely to prevent, any other complications related to multiple pregnancy. The most common complication in multiple pregnancy is preterm labor. So that is, you may start getting labor pains at a much earlier stage, and you may deliver earlier, and babies may require NICU. So all of these pregnancies need to be closely monitored. They must be given tocolytics. Tocolytics are nothing but medicines to prevent preterm labor pains. So your gynec will put you on those tablets. You may be advised a little more rest compared to a normal pregnant patient after during your third trimester, especially to prevent any preterm rupture of membranes, because when you are carrying two babies there's a lot of pressure on the cervix. So when due to long standing hours or if you are working, it may put undue pressure and may result in premature rupture of the membrane, which is the bag of membrane surrounding the baby. So in such patients, what can happen is that you may have to deliver you early because the liquor has drained out. Now, coming to drainage of liquor, so that is premature rupture of membranes. Again, it can happen in any patient, maybe due to chronic vaginal infection, or sometimes even after keeping a relation during third trimester, because a lot of pressure, it can result in premature rupture of membranes. So, what do you do in such situations? So that will all again depend upon the gestational age. Suppose it is around, say, just close to term at 35, 36 weeks, and if there is we need to monitor if there is no infection being there, then probably we may give a steroid cover and try to extend the pregnancy for few days and then deliver. But if it happens at a very early stage, let's say 30, 32 weeks, we may or we may not be able to prolong the duration of pregnancy depending upon the surrounding liquor level, measuring your uh, total counts and CRP levels to see whether there is no infection setting in. And depending upon that, a call will be taken by your gynec whether to how long we can prolong the pregnancy. Now we have many questions from the audience. I'll just take them one by one. So someone is asking you a history of diabetes and I'm overweight. I'm thinking of planning pregnancy. What should I do before planning? This is a very, very valid question. So obesity indirectly does affect your chances of getting pregnant, as well as during pregnancy you have high chances of developing high bp and your sugars. You're already diabetic, so probably it will be difficult to keep your sugars under normal range if because of obesity as well. So, I would advise you to get your basic workup done, get your thyroid levels checked, your prolactin levels checked, get your sugars measured, your fasting sugar, your postprandial sugar, your HbA1c, which will tell us what has been your sugar levels in the during the last 3 months, how much they are under control. Get your sugars under tight control before planning pregnancy. Try losing weight, at least if you're, I'm not sure what your weight is, but if your BMI is high or you fall in the obesity category, try losing at least 5 to 10% of your body weight before planning a pregnancy, because later on it is going to help you during pregnancy and to avoid any complication during pregnancy. Even during pregnancy, get in touch with your gynec, and she or he may be monitoring a pregnancy quite much closely, doing certain basic blood tests which are required to be done during pregnancy, and put you on oral hypoglycemic drugs. If the sugars are not maintained with that, probably insulin may also be required in your situation. Okay, there's one more question regarding my BP is under control with medications and I'm planning a pregnancy. What additional care I need to take? Now, your BP is under control. That is why you can plan your pregnancy, but I'm not sure which antihypertensive medicines you are taking at present. What I would suggest is that you can get in touch with us or with your gynec, and before planning, after you get pregnant, your antihypertensives which you are taking, if they are not allowed to be taken during pregnancy, probably we'll have to switch over to the medicines which are safe to be taken during pregnancy. Usually chronic hypertension patients don't develop that many complications compared to patients who develop pregnancy induced hypertension. So as long as your BP is under control, you follow a salt free diet with regular checkups with your gynec, and then shouldn't be a problem in your case. Probably your gynec may even add aspirin when you're if you are a patient of chronic hypertension. There's a question: various complications that develop during pregnancy which can pose risk. Now there are various complications which I've already discussed, be it diabetes, hypertension, multiple pregnancy, recurrent pregnancy loss, any infection. What So the complications can be, suppose a low lying placenta, that is the placenta is situated at a lower level, so that can cause suddenly bleeding during pregnancy. So we need to monitor them closely and see to it that we may even have to deliver if the bleeding doesn't stop, and may because it may harm the baby. Secondly, if a patient has have any history of previous surgeries like myomectomy, they have been operated for fibroids, so there is a scar on the uterus. So already the uterus is the uterine wall is weak. So we may have to plan delivery in such patients by 37 to 38 weeks. Previous history of cesareans, if you have history of more than two cesarean section, there are chances of placenta being stuck to that scar, which is resulting in placenta accreta or percreta. Obviously those cases are rising day by day because of increase in the number of cesarean sections, those patient planning second or third pregnancy. So we need to monitor what is the position of the placenta to rule out any percreta or accreta being there. Obviously, during surgery also, this cases during pregnancy may they not have any complications, but delivering this patient would be little difficult because the bladder is little pulled up. It may be stuck to the uterine wall. So while delivering the patient, there can be some in-drop complications faced by the surgeon. Um, what is pregnancy risk? Type C. I think this is what you mean by category C drugs, which are to be taken during pregnancy. There's nothing like pregnancy type C. So there are certain medicines wherein the benefits overweighs the risk, and the certain benefits where the risk overweighs the benefit. So talking about second, these are category C drugs, which should be avoided during pregnancy as much as possible until unless it is life saving for the patient. So there's a lot of list of certain antibiotics, certain painkillers, or certain other beta blockers or something which should be avoided during pregnancy. And I think we have discussed almost everything. If there are more questions, there is one. Why is 10 weeks of pregnancy the worst? So it is not worse. Actually, first trimester is extremely important because this is the time sometimes you may not be knowing your you may be having some underlying condition which you may not be aware about, and during those first trimester you may have complications like PV bleeding or spotting, or sudden heartbeat suddenly goes away. So it may happen during first trimester. Usually any genetically abnormal baby, the heartbeat usually comes around 6 to 7 weeks and suddenly disappears on 9 week scan. Or any autoimmune diseases also results in an abortion during that time. So that's why you must have heard your moms and relatives also saying, first 3 months of pregnancy are extremely crucial. Why they are crucial? Because most of the early abortions happen in first trimester. Most of the underlying conditions are detected during first trimester, and probably you may detect it late after a complication has happened. So as soon as you get pregnant, be irrespective of any age, there is a misconception that हमारे यहाँ तो हम डॉक्टर के पास डायरेक्टली 3 महीने के बाद दिखाते हैं प्रेगनेंसी में, इतना जल्दी दिखाने की क्या जरूरत है, इतने सारे सोनोग्राफीज कराने की क्या जरूरत है. That is absolute a misconception. You all are privileged that you all are living in a city where you have all the advanced facilities available near your house. So as soon as one gets pregnant, or even before planning a pregnancy, you should visit your gynae, especially at this in this era where people are planning pregnancy at a later stage of life, at post 35 years of age. So all these pregnancies, all these patients do fall in high risk category. So meet your gynae, find out any whether you are having any underlying problem. So many patients we face, for the first time they just come for a preconceptional counseling. At that time they come to know that they have been diabetic and they were just not aware about it, or the BP was high and they were not aware about it because they don't even get a routine checkups done. Or they may be having some underlying autoimmune disease. Your thyroid levels may be suddenly high, and then you come to know that that anti-thyroid antibodies are also positive in those patients. So these conditions we can pick up much prior to you conceiving. So once you conceive, we already know these are the complications which we may face and which we can avoid. Is double marker test necessary? Yes, it is absolutely necessary. So what is basically double marker test? It is a blood test which is done at around 12 weeks of pregnancy. It is done between 11 plus 5 weeks to 13 weeks of pregnancy, wherein they correlate the blood levels of two hormones with your sonography report, and a risk factor is given whether the pregnancy is of low risk, high risk, or moderate risk. Basically, it gives a risk factor against three conditions, that is Down syndrome, Edwards syndrome, Patau syndrome, and any neural tube defect. So these are the three most common chromosomal abnormalities or genetic disease faced in the baby, which can be detected at a much earlier stage, around 12 weeks of pregnancy, on sonography as well as on a simple blood test. So if your report says that it is falling in a high risk category, then further investigations are done. That is, one is non-invasive prenatal testing, wherein a blood of mother's blood is collected and they extract the fetal cells, because some amount of fetal cells do circulate in the maternal circulation. So they extract those fetal cells, and they do the genetic testing of the cells, and it is 99.9% accurate to tell you whether there is any genetic abnormality in the baby. So genetic abnormality is detected at a much earlier stage rather than detecting at 19-20 weeks. Similarly, with double marker test, so now since we are discussing about the important tests to be done during pregnancy, Along with double marker test, do an NT scan, which is again done on the same day as you collect the double marker, which is nothing but a knuckles translucency scan, which is done by the fetal medicine specialist. They will detect certain soft markers on sonography, which may predict towards a genetically abnormal child. Then, along with NT scan, a double marker test is done. At around 16 weeks of pregnancy, we can do something called as a quadruple marker test, wherein again certain hormonal levels are measured in the mother's blood and a risk factor is given whether the pregnancy falls in the high risk category. And at around 19-20 weeks, what we can do is an anomaly scan, because by 20 weeks, all the major structures of the babies are developed. So a fetal medicine specialist will do this scan and will rule out any structural abnormality in the baby. Those patients who are having diabetes or having any previous baby with a history of a heart disease must also get done a fetal 2D echo, wherein the structure of the heart and the other way parameters of the heart are studied at around 22 weeks of pregnancy to rule out any abnormality in the heart this stage. So I think we had a very good session. I hope I have covered all your doubts related to highest pregnancy. After watching this video, if you still have any doubts, some query, you can contact us. You can put your questions in the comment sections and get back to us, and we'll be very happy to answer. I wish you all a very safe pregnancy, those who are currently pregnant or those who are planning to get pregnant. Happy Saturday. Thank you so much.